6:30. So welcome everyone to the 16th Rural Health Equity Chat. It's a pleasure to see you all here again. And today our topic is going to be the Digital Health Toolkit for Multidisciplinary Teams, particularly looking at rural Wales. For those of you that haven't joined us before, so these sessions are set up to try and raise awareness around rural health equity issues, to provide a space to discuss research, activities, projects, solutions that are happening in different places around the UK and more broadly, and to learn, share, and possibly collaborate together on some of these things. My name is Veronica. I am your host and a rural GP and founder of Rural Health Compass. And today's session, as I mentioned, we're going to look at digital health tools. And our guest today is Tim Smith. He's a Bevan Fellow and business manager at Powys Teaching Health Board. And I will hand it over to Tim in a minute. After his presentation, we will then have time for questions, discussions, and sharing of experiences. So Tim, I will stop sharing my screen and let you show your presentation. Please go ahead.
Fantastic. Thank you, Veronica. And hopefully that will be sharing. Brilliant. So thank you all for your time today, and thank you to Veronica for the kind invitation to present today. As Veronica's already mentioned, I'm currently in the midst of a Bevan Fellowship, which is a 2-year research programme to look at a particular issue in healthcare and look at the ways that we can share good practice, experience, knowledge, and hopefully learn from each other. So very much chiming with the purpose of this particular group. One thing I'd like to do is put a little caveat on this in terms of the toolkit. Those of you expecting a nice polished complete toolkit where it's like a complete set of tools you can just take out the box and hey presto, you've got an inclusive service. I really hate to break it to you. It's not going to happen. This is, and it almost certainly always will be, a work in progress. And one of the things that comes out of research obviously is that more research is needed, but also that there are no easy answers. So I'm going to start off, I'll introduce myself and give you a bit of an idea why I'm talking about this today. So my name's Tim Smith. I'm currently business manager for the Powys Living Well service. We're based in the south of Powys, in the middle of Wales. My service supports people with long-term health conditions, specifically persistent pain, chronic fatigue, the impact of long COVID, and severe overweight and obesity. We're based in Powys. We're based in the south of Powys physically, but we cover the entire county. In terms of the wider picture, in terms of Wales, something like 1 in 3 people in Wales lives in a rural area. Powys specifically covers something like 25% of the land mass of Wales, but we have only 5% of the country's population. So rural is kind of what we do in Powys. Geography, rurality, limited transport networks. It's quite sparsely populated and it's quite difficult to get to healthcare settings in Powys. So we need to look at doing things differently. Other roles mentioned on the screen there. I'm chair of the community of practice. So one of my passions is about digital inclusion specifically. And I chair an informal digital inclusion, accessibility and education in health and social care in Wales community of practice. We draw interested members from across all of the Welsh health boards, the trusts and various organisations, public, private and third sector, who support us to deliver health and social care services in Wales. If anyone's interested in that, please do feel free to make contact with me afterwards. And I've also included a brief link to my Bevan Fellowship project page there, just so you can get a flavour of what the overarching sort of plan of the project is. So in terms of Powys, in terms of service delivery, we don't have a district general hospital in Powys, which makes it quite challenging to provide care. Our residents access acute hospital care from something like 15 providers around our Welsh and English borders, so we're quite spread out in that sense. In terms of the service offering that we offer within the Living Well service, we use virtual appointments for something like 90 to 95% of our contacts, just to reduce the need for people to travel across the county. It also by happy coincidence, allows us to provide better support for those with additional needs. People who, for example, need interpreters, people who need translators, people who need content in different formats. And we're not afraid to work with, frankly, whoever we need to work with in order to deliver that service. So as I'll come on to a bit later, we've got a number of well-established partnerships in terms of access to technology and support for building confidence and digital skills. One thing I want to make really clear before I go into the main slides is that we work with people as individuals. So we don't work with them according to the labels and the conditions that they refer to us with. We don't treat people as patients. They're not waiting for something to be done to them. They're individuals. They're people who've got hopes, dreams, aspirations, and we work with them to hopefully get closer to achieving those. So the Bevan Fellowship itself is split into sort of three parts. There's a research element looking at the balance between digital first, digital only, and in-person provision of services. There are some services where, frankly, there is no other option. You have got to be there physically in the building. It's very difficult to take someone's tooth out by Teams call. In terms of research as well, we're looking at identifying and promoting good practice in the use of digital tools and digital approaches. And hopefully that's something that we'll be able to look at in a little more detail this afternoon. In terms of tangible outcomes, outputs, we're looking at prototyping a toolkit for service review and service development to help individual teams understand the needs of their service users. And this is applying general concepts that any service could use to assess how inclusive, how accessible it is for its own population. Most importantly, although it's last on that list, is about encouraging wider conversations about accessibility and inclusion in service design. The one thing that I say whenever I give a presentation is, no matter what you take away from the presentation today, take away the idea that actually, individually, we can all make a difference. If we start talking to other people and we start working together, we can really make system-wide change. So what kinds of things am I looking at in terms of toolkits? I'm looking at practical approaches, and we're going to look at some of those this afternoon. So an easy example, just to start off at 10, I mentioned about the Living Well service, and I mentioned that we support a chronic fatigue pathway. Typically, main assessments are held in morning clinics, 9, 10, 11 o'clock slots. They're quite long assessments. So one of the things that we've done within the service is say, well, actually, it doesn't make any sense. If someone's been referred to us with chronic fatigue, why are we offering the next available 9 o'clock appointment to them for their assessment? Why don't we try offering them a later appointment in the day? Better still, why don't we give them a ring and ask them what appointment time would actually suit their current lifestyle and pattern? And I appreciate that that's not always practical for some clinical services. So the overarching theme across everything I'm going to mention this afternoon is not about healthcare specifically, but it's about working with people, and it's about taking that citizen first approach. Now, I mentioned at the start, I mean, we offered 95% of our contacts virtually, digitally. I could come out and I could say, hey, we're amazing, we're a digital first service. But that's a bit wrong, isn't it? Because that's putting digital before the people that are actually here to support. End of the day, the reason why all of us are here is to support individuals, to support people. So it's supporting our citizens. And my argument here is that for healthcare to be genuinely inclusive, it's not just about being able to access services. That's really important. But it's also about empowering people and giving people the sense of agency to be able to navigate, understand, and use those services effectively. It's great getting people through the door. That's a key part of it. But it's really important that once they're through that door, once they're part of the service, they're able to engage and get something from it. Here's an idea for you. User personas. So one exercise that we do as a clinical service is we use something called the hero's journey storytelling approach. It breaks down the journey of an individual. It's a technique that's used by screenwriters in Hollywood and elsewhere to understand the background of an individual, the challenges they face, how they rise to meet those challenges, how they overcome challenges but maybe encounter setbacks, how they bounce back from that and lead a happy life. cowboys riding off into the sunset. Yeah, the nice, hopefully happy ending. It's about understanding people. So one way that we use as a service to understand the people that we work with is we've created a set of user personas. And you can see, hopefully, just enough detail on here to understand what I'm talking about on the screen. There are 3 elements of this user persona. The one in the center, I find really, really important. Because one of the things that's changed, certainly within Powys over the last few years, is that we are a rural service and we serve a rural population. But the people who are serving that population are actually travelling a long distance to come and work here. So we've got people who come up to us from Cardiff or Swansea, quite normal metropolitan settings, cities, who are then providing support in Powys, big rural county. Perhaps not fully understanding or recognising some of the challenges that the rurality brings. So what we want to do is we want to remind people of the impact of rurality. We want to remind people about the individuals and the populations that we serve. So you can see in the centre section of the slide there's a snippet from Google Maps that shows a couple of miles square area around an individual. It also includes transport links on the right-hand side, typical times to get to, in this particular example, our base in Broadleys in the south of the county, by driving or by public transport. And the public transport one is the one that always makes people flinch. An individual asked us for an appointment and was insistent they really, really wanted to be seen face to face, but they don't drive. So we worked out the public transport and it was 5 hours each way. And to get home, they'd be on the last bus. And there were no options. So if you miss the last bus or the last bus inevitably breaks down, it becomes an even bigger challenge. These personas are based on composites of people that we see within the service. They're not based on recognisable individuals. They're based on the data that we hold as a service, but they're also based on clinicians' experience of working with individuals. And we try and put together a balance of a number of typical people, those fairly straightforward, as expected people, and a number of edge cases, those people who maybe have got unexpected challenges or particular needs that are going to be need to be catered for by the service. And we use these personas to define typical goals that people might have, typical health situations they might come to us with, where they get their source of information. Are they getting lots of health information from social media? Are they very health savvy, I guess? Are they very tech savvy? We use these to define typical service users. In our main meeting area, our session room where we hold our MDT meetings, these personas are all up on the wall. They're there to ground the team and remind people about the challenges that we face. And they're there when we do service development exercises and training sessions. It's about understanding what makes our population tick and about understanding some of the challenges that people face. It's really simple. It's a fun session to do. It takes maybe an hour, hour and a half to put one of these together with a team of people. It can be a really good source of discussion, conversation about what's going on. I've talked a lot about the service users, about the individuals who come into the service. It's also important to recognise that we need to support our staff. We need to support our team. And I think one of the biggest things that has come out of experience across Wales, frankly, is challenging people's perceptions of things like virtual appointments, challenging people's perceptions of, dare I say it, I'll say it quickly, the NHS Wales app. There, I said it, it's done. By training staff, by giving them the confidence and the experience, staff can effectively challenge people's perceptions and objections to using, let's say, for example, virtual appointments. Lots and lots of people say, well, I've been referred to a pain service. I need to be seen. You need to see me to understand my pain. Yes, we do. It's really helpful to actually be able to see you. We don't necessarily need to see you physically in the building. We do sometimes. Majority of people we can actually assess quite effectively through virtual consultations, through having video consultations. What we found a couple of years ago was when video consultations were being sort of rolled out and promoted, was that the staff making appointments had never used them before, didn't understand them. And we were finding that there was really poor take-up. It's like, hang on a minute, we've got this amazing tool, people wouldn't have to travel 3 hours to see us. Why are they not using it? And it turned out, to a large extent, that it was not really being sold. And it was not being sold because the staff selling the appointments as virtual appointments didn't understand how easy it was to get into them, didn't understand what you could do once you were in a virtual consultation, didn't understand how you'd appear when you were in a virtual consultation. So one of the things that we've done within the Living Well service is we built this into our induction process. Any new starter, clinical or clerical, goes in as a service user first. They get to see what the people see. Then they go in as a service provider and understand the other side of the consultation. Building the confidence, building the experience makes for a better sales pitch, means that more people are taking up the virtual appointments, hence 90 to 95% virtual contacts. But we're in a rural area. I get that. Rural areas bring all sorts of challenges. I'm presenting today from work because we've got the benefit of a fantastic fibre broadband connection, which hopefully is keeping up with me this afternoon. If I was presenting from home, the connection would be poor, to say the least, and would depend on whether the squirrel was jumping up and down on the copper wire at the time. Connectivity is a challenge. Technology can be a challenge. In Powys, we're very lucky. We've got one area of deprivation that's in the most deprived decile in Wales against the latest measures. We've got an awful lot of areas that are in that low end of the scale where we have got pockets of deprivation. We've got areas where people don't have the resources to be able to join virtual consultations. So what have we done about it? Well, this comes back to the start where we can do a lot individually. We can do a lot as a service, and we can tell people about how wonderful it is, and we can give people support. And we've got a team of digital facilitators. I've got 2 part-time colleagues in my team whose role is basically to contact people, make sure they understand that they've been referred to this service, understand what their needs are in terms of mobility, in terms of language, and in terms of digital skills. And wherever possible, we offer a one-to-one digital support session to boost people's confidence. As I've just mentioned about the staff getting confidence, let's get the service users confident with the digital tools we're using as well. And then hopefully they'll be able to concentrate on the clinical reason that they're coming to us rather than panicking about the technology. Sometimes it's as simple as that. It's a phone call. It's, have you tried this? Let's have a go at this together. Sometimes people don't have the devices. Sometimes people don't have the connectivity. So we've got a partnership in place with our local library service. We're incredibly lucky in Powys. Our local library service has got 140, 150 iPad devices, including 4G data cards that they're willing to loan to Powys residents. We've got a referral process in place between the health board and the library service where we can say who wants the device, when they're looking for it, and where is their nearest library to be able to collect it. By the time it gets to the branch, the device, the iPad usually, is prepared for loan. There's no trace that it's actually been a health board referral at all. It's just a device waiting for someone to pick up. So there's no stigma attached. We make it as easy as possible for people to engage with us. If someone's got their own device, but they haven't got connectivity, through the library service and through other partners that we work with, we've also got access to the National Data Bank through the Good Things Foundation with the data SIMs with 6 months of data on that we can gift to people to be able to connect. The library iPads come with data preloaded on them. We've also got an arrangement with the libraries where basically Teams calls and Attend Anywhere, which is a virtual consultation platform, calls are prioritised. So if someone's running low on the standard data, those calls will still go through so they can still engage with the healthcare. A number of the libraries have also got individuals in place where they can provide face-to-face support as part of the referral process. And one of the things that's probably as important as the technology but doesn't get mentioned in my eyes nearly enough is most of the libraries are also able to provide a safe space for people to engage. Sometimes you've got the technology, you've got the connectivity, you've got the skills, you just haven't got a quiet, safe space to be able to engage with healthcare in a kind of a confidential setting. So the libraries have privacy pods and have areas that they can put aside where people can actually engage in healthcare. That covers 95% of the population. By the time you've gone through the people who've got their own devices, people who can borrow devices, people who can get connectivity, people who can get space, there's a small proportion then who've got additional needs. People who self-identify with disabilities, people who have got registered disabilities, whether that's sensory impairment, cognitive impairment. And we've got a partnership with a fantastic third sector organisation called Accessibility Powys, who are able to go out to people in their own homes, do risk assessments and provide customised devices for them. So it may be a case of setting accessibility settings on an iPad. It may be a case of providing a custom keyboard or with a trackable type mouse rather than a normal desktop mouse. So we've got the full range of support there. Again, comes back to the key point. We can do a lot individually, but it's about talking to people and working with whoever's around us to go out and do more together. Accessible material. Sounds obvious, doesn't it? We did an exercise back in the summer to look at our support material and look at the content and the formats of material that was going out. It wasn't good. I'll be honest with you, it wasn't good. We had to stop and we had to think, actually, right, a real person is going to use this. What are they going to get from this? What are the key messages that someone who's never seen this before is going to be able to take away? And I think it's really important to draw a parallel between improving someone's digital literacy to improve the skills to access things, but also improving someone's health literacy to understand their condition, to understand what's happening to them, and to understand where to get sensible information to support them. Part of that is about providing information in an accessible format that people can actually get to grips with. So it's about using simple language. I mentioned this on a call a while ago and someone really got offended, so I apologise if I offend anybody on the call. Right for a 9-year-old. There, I've said it. If a 9-year-old can understand it, a 90-year-old can understand it. You're hitting everybody. If you write it for someone who's got a doctorate, you're missing a large population. Simple. Try and provide things in multiple formats wherever possible. Try and recognise the needs of your individuals. I was very fortunate to have a business support manager work with me a year or so back, who was fantastic at the job they were doing, but they were dyslexic. And one of the challenges with her experience of dyslexia was we were churning out lots and lots of documentation on white paper, and it was all closely printed. And the description that I had was, it's like the words are jumping around in front of me. How can you address that? We found a really simple way that works for a large number of people. It doesn't work for everybody, but then what does, frankly? We found that using a parchment background, so the same color as the background of my slides today, actually improves the readability of a document for someone. So it reduces the amount of jumping around that those words are doing, which then hopefully helps them focus on the meaning that you're trying to get across and get more out of the document itself. We try and use video wherever possible. We try and ensure that we've got subtitles on there. And one of the things in Wales in particular is we've got a statutory duty to deliver content in Welsh. But we also recognise that there's a proportion of our population whose first language is Welsh, and we respect that. We ask them as part of the referral process what their preferred language is. We respect that and we provide information in their preferred format throughout their time with the service. So you can see one of the examples there on the left of the screen is welcome pack in Welsh language. It's all about understanding the individuals that we're working with. It's all about understanding their experience. My advice to everybody, whatever type of service you run, is just once, put some time aside to take a step back. Stop thinking about the immediate needs, the immediate list of appointments that need booking, the immediate people that need to be seen. Take a step back. And from the very start, try and understand what people see, what they do, what they get as they come into your service and as they work with you. Try and put aside the preconceptions of what you think they're seeing and getting, and try and work it through as a structured approach in terms of actual documents. The aim is to reduce basically failure demand, making sure that you've got the right people, the right information, the right equipment in the right place at the right time. It can be incredibly complicated. So you can see an example on this slide where we took everybody down to University of South Wales in Treforest, and we ran a simulation exercise in the Hydra simulation suite. Absolutely fantastic. Really recommend it. Happy to talk to anybody who wants to find out more separately. I could be on for like 3 hours just about that otherwise. It doesn't have to be this complicated. It can be as simple as the documents that are on the far left in really, really blurred type, where you make up a referral, you make up a set of test results, and you challenge the team. Okay, this is what has come in. What do you do with this information? What do you do next? Who's involved? How does the person sending the referral in know what you're doing? How does the person the referral relates to know what you're doing? What happens next? Challenge people to think about it. We did this with someone coming into our service. Things that came out of it: accessibility of content, things about reminding people about appointments. How do we remind people about their appointments? Things about the language that we're using in the letters. Some of the language was frankly really, really confusing. Whatever you choose to do, it's really important you understand the impact of what you're doing. And I'm sure I am singing to the choir. Measure. Build in outcome measures, build in experience measures so you can see the impact of what you're doing. Whether that impact is a good impact, which is what we're hoping for, or a bad impact, a negative impact. And it's important to be able to see that, recognize that, and then examine why things may not be going to plan. Again, I feel a bit preachy when I'm doing this, but person's experience, patient experience, is not just about the individual person in front of you. It can also impact the community that's around them, the support network, their family, their friends, their colleagues, and the perception of the quality, the availability of services that are available. And that perception out in the community can then lead to people making arguably poorer decisions, seeking help from sources that are less than brilliant, going straight to A&E when they bang their toe on the door rather than stopping and thinking and maybe going to see a pharmacist if they need something. People missing the best options. So what we really want to do is we want to capture the user experience, the patient experience, and we want to understand where it can be improved and work to continually improve it. Final slide, I promise. Particularly thinking about the people that my service deals with, we support people with long-term conditions. If you're experiencing persistent pain, chronic fatigue, weight management issues, you don't just experience them between 9 and 5, Monday to Friday. It's a life thing. And the support that's provided needs to be a life thing as well. So it's important to think about the range of support that's available. We've recently expanded our range of supports. We've improved the clarity and the detail of the content that's on our public-facing website. We've also embraced the use of technology to support group programs. So we've got things like workbooks. We've got interactive exercises that people can do. We've got pre-recorded videos, and we've got the face-to-face workshops as well. One of the key lessons that we've learned as we've sort of strayed into e-learning territory is that just giving someone something and leaving them to it doesn't work. It's about building in long-term support to say, hey, have you had a chance to look at this? How are you getting on with this? And check in with people. It's not just a case of click and forget, which is what traditionally perhaps has happened with e-learning, where it's a case of, right, you can do the e-learning, you'll be fine after that. Doesn't tend to work. There's plenty of studies out there that show that engagement rates drop off if you don't provide that kind of wraparound support. I promised that was going to be the last slide, so I kind of lied slightly. This is definitely the last slide. If there's something that sort of strikes a chord, if there's something that you want to talk about in terms of what we do in Powys, if there's something you've seen you want to find out a lot more about, I'm hoping you'll be brave enough to say something in this session. If not, please feel free to reach out. You can find me on LinkedIn. You can find me via my NHS Wales email address. I'm always happy to talk to anybody about digital inclusion and accessibility. And that's me, Veronica.
Thank you very much, Tim. No,